listen-only mode. Later, we will conduct a question-and-answer session. Please note this conference is being recorded. I will now turn it over to Beverly Gorman, the IAAC Director of Accreditation for Echocardiography. Beverly, you may begin.
Thank you, Brandon. Hello, everyone, and thank you for joining us today. This webinar is being presented to you by the SDMS and the ICAEL. First, I have just a few housekeeping items to go over with you. First, the phone lines have been muted, and this is to reduce the background noise so everyone can hear clearly. This presentation is being recorded. The webinar is worth 1 SDMS CME. In order to receive your CME, you must be registered for the webinar. You must individually log on to the web presentation. Even if you're part of a group, go to your computer, log in, log out, and join your group again. Shortly after the webinar, you'll receive a survey in your email for you to complete and submit to us. It is necessary for you to complete this survey by January 18th in order to receive your CME. Please remember you must do all three. You must be registered, you must log into the presentation, and complete the survey to receive your CME. No exceptions can be made. Due to the high image content of this presentation, you may have noticed that you had a black screen with a downloading content message when you initially logged in. Or if you just joined the web portion, you may also see that. The message will go away and you'll see the PowerPoint slide when your computer completes its download. For everyone's convenience, the slides are downloadable as a handout by clicking on the small icon on the top right-hand corner. It kind of looks like 3 pieces of paper, so you can download the slides from there. It is my pleasure to introduce Pam Burgess to you. Pam is the manager of cardiac ultrasound and stress testing laboratory at Wake Forest University and Baptist Medical Center. She has more than 25 years as experience as a sonographer. Pam also serves on the ICAEL Board of Directors representing the SDMS. Not only is she on the Board of Directors, she's also a reviewer and site visitor for the ICAEL. Pam is also a fellow of the ASE, where she serves on several committees. And as an educator, she serves as an instructor in the adult echocardiography course at Wake Forest University School of Medicine, and has served as a speaker and director at numerous echo courses across the country since 1993. It is again my pleasure to turn this presentation over to Pam. Pam?
Thank you, Bev, and thanks everyone for joining today. When deciding on the topic for this webinar, I wanted to decide on a topic that would be appealing to even the most experienced sonographers. And that was a little bit difficult, to try and find something. So, talking to Bev back and forth, we decided that it would be good to go with just a basic lecture on optimizing your echo images. As we all get busy in our echo labs today, we find that it's just easy just to go through the patients and not really optimize the images as much as is sometimes needed. So I thought this would be a great review for even the most experienced sonographers, and then a good review for, even the newer sonographers as well. So, sometimes we just forget to optimize, and hopefully this will be a good review for everyone. Okay, some objectives for this webinar today will be to provide the sonographer with helpful pearls and methods for improving 2D images and Doppler evaluations, provide examples of common errors made with 2D imaging and Doppler, and to explain the benefits of contrast utilization during transthoracic and stress imaging. Okay, so let's begin by talking about where we place the transducer on the chest wall. And I realize this is very basic, but I think it's something that we need to talk about as well. Remember that we like to image as perpendicular to the walls as possible. If you notice, the image on the left is at a lower parasternal window, so therefore we're not hitting the images with the ultrasound beam as perpendicular as we would like to. So a good rule of thumb is to start high on the chest wall and then move down, to where we find our window. I realize that we can't always get an image like the one on the right where we're equal distance from the septum and the aortic wall, and sometimes may have to resort to an image like the one on the left, but at least we've tried and tried to become as perpendicular as possible for our patient. You notice the quality difference between the two images here. The one on the right is of much better quality, but just simply because of the way we're hitting the walls more perpendicular, which is what we know allows us to have better image quality. Okay, so once we found our window, we move on to our 2D measurements here. We like to find the longest axis of the heart while we're making sure that we have the left ventricle, the left atrium, and the aortic root wide open to where we can make our measurements of the largest area of the left ventricle and also of the aortic root as possible. You notice here that we make our measurements straight down through the interventricular septum, down through the posterior wall of the ventricle, and also down through the aortic root and down into the left atrium, just in the same planes there. Okay, here's an example of where we can have some common errors that we will see. Here you notice the right ventricular trabeculations on the right side of the septum here, where I have the white arrow. And those trabeculations can sometimes be seen in patients there. And a common error we see is to include those trabeculations in the interventricular septal measurement. And we know that when we see this, we should try and reposition our image and try and get rid of these, or at least not include them in the septal measurements. We also may have an issue when making the posterior wall measurement, whereas the chordae usually lie right in the area of the posterior wall where we make the measurements, and those a common error we see there is to include those in the posterior wall measurement. Also, when we're making the aortic root measurement, we have to deal with calcifications in the walls of the aortic root at times. So we need to be very careful not to include those in the measurements as well. And you may say, well, Pam, what do I do if they're there? Well, try and reposition your image and just get rid of those. But if you can't get rid of them, just don't include them in the measurement if at all possible. Okay, another example of where we see a common error made is, where do you measure the septum on this patient? This particular patient has an area of focal hypertrophy in the septum, in the basal septal area there. This is something that we commonly see in the elderly patients, and it makes it a little difficult for the sonographer to make the decision, where do we measure on this particular patient. If we measured where the red line is there, we would give this echo the appearance of having septal hypertrophy. Whereas if we move down the septum where the yellow line is, we would have a more accurate measurement of the interventricular septum and not include that focal area of hypertrophy there. Okay, next let's talk about left ventricular outflow tract measurements. Some tips for a better measurement here. We know that this measurement's very important when we're doing or when we have a patient with aortic stenosis. This is one of the parameters that we measure that's included in the continuity equation. And this measurement is also squared in that calculation. So it's very important that we don't introduce any error in that, because we know if we introduce a small error into that calculation, it becomes a large area with this particular measurement. So we want to become as perpendicular to the left ventricular outflow tract walls as possible. We want to zoom over the left ventricular outflow tract. Again, adjust your gain, your focal zone, and also your frequency. Remember, the left ventricular outflow tract is a little superficial in the heart, so we may even be able to come up on the frequency there and improve our resolution. Also, we like to measure about a half a centimeter below the aortic valve. measured during systole, and we in our lab like to measure this at least twice just to ensure that we get a good measurement. We also avoid any calcifications that may be present in the left ventricular outflow tract. Okay, here's two examples of left ventricular outflow tract measurements. The sonographer on both of these has just about done everything right. They've zoomed up on the left ventricular outflow tract, they've adjusted the focal zones, the gains, and also made the measurement during systole. The image on the left is a somewhat more difficult patient than the one on the right, but you can, if you'll notice the way the measurement has been made, here the sonographer has angled the measurement through the left ventricular outflow tract instead of being more perpendicular to the walls here. You notice the image on the right, the walls are lined up perfectly perpendicular, and also the measurement has been made perpendicular to the walls of the left ventricular outflow tract. So the image on the right is a lot more desirable measurement than the one on the left. Okay, next we're going to move on to optimizing the 2D image and really talk more about the gain settings, and this really more about the overall gain settings. How many times have you sonographers gone in the reading room and maybe talking to your physician about the image, and when you're there you notice that the image looks quite different from what it did on the ultrasound machine? This can come from the monitors on the ultrasound machine being adjusted, maybe the contrast turned way down on it or turned up, and this can affect the way you set your overall gain on your image. So this easily happens when we're cleaning our screens and things like that. Also, the images on the monitors in the reading room can come to a point where they need adjustments as well, so be real careful with that. Also, just check your images and make sure that they look the same in your reading room as they do on your monitor. If you look at the three images we have here, the one in the middle here is where it's a gain set more optimally. You notice that we can see good endocardial definition, throughout the image, even in the far field versus the near field as well. The image is nice and cleaned up. If you'll take a look at the top left image, you can see there that the overall gain setting is set too high, and this can cause the image to degrade somewhat, where it's a lot more difficult for us to see the good endocardial definition or even the valvular structures on this patient. So the gain in this top left image needs to be cut down slightly, and this is something that we see a lot of the times. If you'll notice over on the image on the top right, the overall gain has been set too low. So we really see a lot of loss of the image quality here due to this. So, and this is something that could commonly happen with just a monitor adjustment on the equipment there. So just make sure that your overall gain is set optimally for all your monitors and everything. Okay. Near-field gain is another thing that we see a lot of times, and we see this in our labs sometimes, where the sonographer just does not take the time to clean up the image thoroughly. Okay, if you notice here on the image on the left, the peristernal long axis view here, we have the near-field here has a lot of overgain in the right ventricular area here. And what this can do to your images, it causes you not to be able to see your right ventricular free wall, fully evaluate that, or there could be a structure, some pathology right in the right ventricle there that you could miss. It also maybe causes you to not make as good a measurement of the interventricular septum there as well. So this is something that can easily be cleaned up utilizing your TGC gain, which allows you to clean up the image at certain depths and everything, or even bring out at certain depths. Like if you can't see your posterior wall well, you can just make an adjustment with your TGC gain to help bring that out for maybe some measurements or something. The image on the right is an apical 4-chamber view where we've decreased the depth setting here, so we're just focusing on the left ventricle. You can see how overgained this is, especially in the apical area here. And if this image were moving, you would notice that we don't see good endocardial definition here anymore, whereas if we just went back and optimized the gain settings here with the TGC, we could really bring out good endocardial definition in this patient. And, just remember that, well, throughout this presentation, I'm going to be giving you hints, too, as to some of the things that the ICAEL reviewers review on your studies when you're sending those in for your accreditation or reaccreditation. And one of the things we do is that, that you've set your gains properly. So another helpful hint for you to when you're picking your studies for that. Okay, this is we're going to talk about next is focal zone. And this is a short axis image of the aortic valve. And I'm sorry, but it's not moving right now, so it's a little, maybe a little more difficult to see. But it was one of a bicuspid aortic valve that we had zoomed up on here. So here's the valvular structure, and you can tell that there are just two cusps to this valve here. But this is something we commonly do with our studies when we're looking at an aortic valve in short axis is we zoom on the valve and we make sure that we've set our focal zones at about the same depth as the valve. And what this is doing for the sonographer is that we're telling the ultrasound machine that this is exactly where the depth that we want our optimal resolution at, okay? So we kind of have a dynamic focal zone range or area where we can move this back and forth. If we're looking at something in the far field, we can actually move these focal zones back there and move that optimal resolution area back to that area. So, not only do you want to do this for superficial structures, but you also want to do this for areas back in the far field as well, wherever you're wanting your optimal resolution. So, when you're dealing with your more difficult patients and, maybe, again, looking at the aortic valve for calcifications or to look at the excursion of the aortic valve, this is something you definitely want to do to optimize your images. Always have your focal zone set in that area. Okay, next we're going to move to the sector width. And here you'll notice that the image we have here is the sector width is set fairly wide. You can see the entire heart, you can see the right atrium, the tricuspid valve, and even around over to the pulmonic valve. And we know with our ultrasound sector image that we have a set number of scan lines in our image, whether we're scanning with a wide sector or with a narrow sector. So what this allows us to do with our narrow sector is we can condense those lines down to this smaller sector, so it improves our image resolution for these patients. And, this is a relatively easy patient to scan here. We can see the three cusps of the aortic valve and all. But on our more difficult patients where we're looking to see if the valve opens good or if there's two or three cusps there, we can better evaluate and have higher resolution with this. So this is just a technique that we've done for years in our lab. It helps improve the frame rates, things like that, to better your image quality there. Okay, next we're going to look at frequency. And I can remember the days where we had to actually plug in a different transducer to go to a different frequency. Now the manufacturers have made it very, very easy for us. All we have to do is flip a knob. We don't even have to switch transducers. And you can see here in the bottom left corner of this image where it gives us our frequency of this particular image. If we have a patient that has a relatively thin chest wall, of course, we would want to switch it up and go to a higher frequency versus a patient with a thicker chest wall. It's a little more difficult to scan. We would want to go down to a lower frequency to ensure penetration throughout the image. With that, though, there's a trade-off with resolution. So we always want to scan at the highest frequency possible, to get that maximum resolution of our images. But, even though you've got a very difficult, thick-chested wall patient or something, remember you're still looking at images, things that may be up in the near field, and there may be an opportunity for you to even go up to a higher frequency on these patients. You know, like in this view, looking at the apical area here in this apical four-chamber view. Okay, so I can remember several years ago when we got harmonics, and I was thinking this is probably one of the best advances we've had in cardiac ultrasound since color Doppler. And yes, I was scanning when we first got color Doppler, so I've been around for quite a while and seen a lot of great advances with cardiac ultrasound, but I think harmonics is probably one of the better ones that I've seen. The image on the left has no harmonics to it. And it's kind of hard to remember back to these days because I think now most of us just turn harmonics on and leave it on pretty much throughout the study, so we don't even, you know, really realize how we used to scan without harmonics or how the images used to look. But now with harmonics, the image on the right here, you can see that the image is a little more contrasty. It helps to bring out the endocardial definition here. This helps a lot when we're evaluating the left ventricle, whether it's with a transthoracic echo or with a stress echo. It really helps us to see that good endocardial definition. And, you know, let's remember what harmonics does for us. It sends out the signal at a low frequency, so we get the ability to penetrate these areas in the far field, and we receive back at a higher frequency, so we get the better resolution. So we kind of get the best of both worlds with harmonics, and plus it brightens the image up a little bit too. What harmonics has, another thing it's allowed us to do is to utilize contrast better. I can remember our first days utilizing contrast. When we didn't have harmonics, we would have to ask each other if we saw the contrast bubbles come in the heart. Now, that's how bad it was when we first started utilizing contrast. But now with harmonics, harmonics really brings out the ability to see the contrast in the left ventricle here. Okay. So next we're going to talk about contrast, and contrast is something that's very dear to my heart in cardiac ultrasound. I've always been someone that really thinks contrast has improved cardiac ultrasound overall. I mean, it's something we use in every modality that we do, whether it's transthoracic, transesophageal, or stress echo. And we, like most labs, started out using contrast with stress echo and then kind of advanced to utilizing it with our more difficult transthoracics. And then also even started using it to bring out certain pathologies, even in the more easier patients, you know, to image. Just we would think that it would help to bring out the pathology that a patient had. I have to say that I think it was a long time coming, but in 2010, ICAEL put out contrast verbiage, and I've included it here. And it's just three kind of simple statements here that if you use contrast, you must have a written policy for the use of a contrast agent. If you're not using contrast, you must have a policy for some sort of alternative imaging. So you just don't leave your patient hanging there. If you can't, you know, see good left ventricular function, they could move on to maybe a nuclear study or something else that would help them out. Also, contrast should be used in the presence of poor endocardial border definition for quantification of chamber dimensions, volumes, ejection fractions, and also the assessment of regional wall motion. And, you know, like I said, I think this was really a long time coming for ICAEL to put that out. I have to say that we don't mind as reviewers seeing studies that have contrast utilized on them. You know, if they're stress echoes, you know what, it tells us that you're going that extra mile for that patient, that you're doing everything you can to optimize your studies, and you're taking that time. It doesn't matter to you if you have to wait for approval, if you have to wait for a nurse to start your IV, to administer your contrast, whatever. You're doing everything possible for that patient to give them the best image possible that you can. Okay, so we're going to move on and look at some images here with contrast. This is a dobutamine echo that was initially pretty difficult. And we all know, sonographers know, that stress echo is one of the most challenging things we do in cardiac ultrasound, especially exercise echoes, where we have to obtain the images in less than a minute. We have the patient coming off the treadmill, breathing very hard, increased heart rates, and actually they may land in a totally different position back on that stretcher than what you initially had them at. So they're very unpredictable at times. You know, you may, with your resting images, which are obtained in a very controlled environment, it gets to be very chaotic at end-post when that patient comes back to the bed. So you kind of never really know what you're going to have when the patient comes back. You know, we do a lot of different techniques where we have the patients breathe hard, stuff like that, to kind of see if the image is still going to be available with them coming off the treadmill and breathing hard. So all these things can kind of help you, if the patient's borderline, to help make that decision on utilizing contrast. You know, we always tell our sonographers it's much better to have contrast on board than to take the chance on those in-post images. You can see here this is a 4-stage dobutamine echo. Top left corner is resting, top right is low dose, bottom left is our peak image, and bottom right is our recovery image, which we take recoveries once the heart rate has come back under 100, and usually all chest pain, things like that, have subsided if they were there. So, and I think this is kind of a unique case, and with, you know, talking about contrast, I want to talk about how you do your stress echoes as well here, because I think it's very, very important that you include a recovery image. And I don't often see a lot of people doing that, but if you look at this recovery image here, you notice that this patient's left ventricle dilated out sometime after the peak images were acquired to the patient's heart rate coming under 100 here. So had we not done recovery images, we would have missed this. And so for that, I think it's very important that on your stress echo images, whether it be an exercise echo or a dobutamine echo, that you always obtain a recovery image. Most of our equipment today will allow you to do a 3-phase exercise echo, which will include recovery, and dobutamines. You can also do a recovery in a 4-stage. So just something that I always like to see people do, just so we don't miss things. Okay, moving on to the next patient. This is a transthoracic echo we were doing, and we do a lot of chemo patients in our lab, you know, whether it's prior to chemo or just a recheck on their left ventricular function after chemo. A lot of these patients could have had a mastectomy, which makes them a lot more difficult. You can see here this image, this patient was pretty difficult. They can sometimes look pretty good with the image moving, but once we stop it and start to run it back to where we're going to trace our diastolic and systolic frames, it's more like connecting dots than it really is tracing good endocardial definition. So we like in our lab to have a very low tolerance for using contrast on these chemo patients, because we know, number one, we're going to be seeing them back in the lab, and we're also going to want to make sure that we have good reproducible results with these patients. And I think that the one thing that gives us that accuracy and the reproducibility is us using contrast. Because here in this apical 4-chamber image on the same patient, you can see that it would be much easier to trace around this contrast border than it was initially the poor defined endocardial border that we had without contrast. So, you know, sometimes these patients come in with having already had their chemo, and if their EF drops, you know, even slightly, they may pull their chemotherapy, and that's something that you don't want to have done to a patient unnecessarily. And this could be life or death situation for them. So we like to make sure that what we're tracing is an accurate trace and is reproducible. So these ejection fractions that we're obtaining on these patients are very, very important for them. Okay, the second half of this, we're going to move into optimizing your Doppler signal. We're going to be talking about color Doppler as well as spectral Doppler with pulse and continuous wave Doppler, and even everybody's best friend here, the PDOF probe. We're going to talk about that a lot too. So, okay, first of all, I like to always say when I talk about color Doppler is make sure that you adjust your 2D gain. This, if the 2D gain is too high, as it is in this particular patient here, you can see that you don't see the color Doppler as well. It can even make it a lot more difficult to see any small jets that may be occurring in the heart. So one thing I like to encourage everyone to do is to just simply clean up your image, go down on the 2D gain. As you can see with this image, same patient where we've just decreased the overall 2D gain. It allows the color Doppler to show up a lot better, and if there were to be a jet of regurgitation there, it would allow us to see that a little more clearly too. Okay, next we're going to talk about adjusting color gain. First of all, I'd like to say that this is something that we should be doing throughout the study. It's not that one thing that you do when you begin your study. It's something you do as you move over the different valves of the heart, especially going from the left to right side of the heart here. We have to be real careful with this, though. If we turn our gain down too far, we could underestimate a regurgitant lesion, or if we have it set too high, we could overestimate it. So we always tell our sonographers here, turn the color gain up until it sparkles, and then gradually lower the color gain just till the sparkles go away. And you'll need to do this throughout your study as you change views or different flow states and all. So this will help to make your color Doppler a lot more accurate. Also, if you notice, sometimes with a higher gain, you can have the color Doppler bleeding over into the tissue. And so we would want you to keep this set a lot more optimally so you could avoid that. Okay, next we're going to talk about adjusting the color box size. I know today that we don't have as many problems as we once did with frame rates when our boxes were larger, but still we like to kind of focus on certain areas of the heart as we move through our exam. On this particular image, you can see where the color box is set very large, okay? You can actually see both the left and right atrium and the mitral and tricuspid valves within this one color box, which is set a little large for what we scan with in our lab. We like to keep it small, keep our frame rates high so our flow looks real fluid. As compared to this image here, where we've narrowed the color box down, made it smaller, we're focusing on one valve at a time as we move through our study here. Okay, and it allows us just to focus on that and get a more accurate reading on the color Doppler there. Okay, adjusting the color Doppler scale is something that you might want to do as you move through your color Doppler study. We know that the flow states are much different on the left side of the heart as they are on the right side of the heart. This is one with the scale set fairly high for the right side of the heart. We like to sometimes decrease the color scale. It'll help bring out slower flow states, such here's some tricuspid regurgitation. Here's where we have actually decreased the color scale on this patient, and at times you can see the tricuspid regurgitation present there. So it just helps bring out lower flow states, see regurgitant lesions sometimes better on the right side of the heart as well by doing this. A good rule of thumb, though, remember if you decrease it down, you need to bring it back up when you move back to the left side of the heart, just to ensure that your color is optimal there. Okay, this next example is color Doppler over the pulmonary veins. I know everyone's probably obtaining pulmonary vein flow with their echocardiograms now. It's probably in your protocol. In the adult lab, it can sometimes be difficult to do to see these. So we like to make sure that we put our pulse Doppler a couple centimeters back into the pulmonary vein there. But we like to localize them first with color Doppler. And here you can see that we can see the color Doppler coming up through the pulmonary vein there. If you can't see this, sometimes a good thing to try would be to lower the color scale to help you image that better, turn your color gain up somewhat, make sure that you've increased your depth far enough that you're seeing back past the wall of the left atrium as well. And I think that will help to improve your pulmonary vein flow there. Okay, next we're going to talk about optimizing your spectral Doppler signal. We'll be talking about continuous wave Doppler, pulse wave Doppler, and we'll also talk about the sample volume placements that we're doing throughout these studies here. Okay, here's an example, two good examples here of spectral Doppler being done with pulse Doppler through the left ventricular outflow tract. If you notice the image on the left, they have really set the scale, the Doppler spectral scale, too high here for the velocity that we're displaying here. And if you notice your 2D image at the top, you notice that there's three different sample volumes there. So you're actually acquiring information from all three of those. So we've got this set too high to where we've scrunched the signal up here pretty small, okay? If you notice the image on the right here, we've actually expanded the scale, same patient here, and notice how much larger the left ventricular outflow tract Doppler is here. It's much easier to see, and we know this is one that we typically have to trace and put into our continuity equation, so it will make your measurements more accurate, easier to trace if you expand your Doppler scale. You know, some other techniques that you can do is to just shift your baseline up. We're not really interested in anything occurring above the baseline here, so you can just display this signal and really expand it out so you only see things that are occurring below the baseline here. Okay, moving on to sweep speed. Increasing the sweep speed can be something that also helps us or improve the accuracy and the tracing ability of our spectral Doppler signals. If you see the image on the left here, we've obtained this with a sweep speed of about 50. It pretty much scrunches up your signals here horizontally, okay? If you notice the one on the right here, we've obtained this at a sweep speed of 100, and it helps to spread out the Doppler signal and for us to evaluate the signal here a little bit better. If we were to have to trace this, it would be much easier to trace than this image over here. Now, I know there are times where we want these signals scrunched up and we want to run them at a lower sweep speed. Say when we have a patient that has a pericardial effusion and we're wanting to see multiple waveforms across here and just to look at the different velocities with respiration, and that would be a time where you would want to decrease your sweep speed so you could see multiple waveforms across there. But when we're making measurements, you know, it's really more accurate if we spread this out, you know, both vertically and horizontally for us. It makes it much easier to trace these signals and get a more accurate trace with them. Okay, PDOF. This is something that, you know, now is required by ICAEL, and, well, it's been required for a very long time now. When we send in our aortic stenosis cases, we have to send in PDOF with these aortic stenosis gradients present on it. We like to see that you have labeled the waveforms here. And see, we got a nice label that says this is done from an apical window, okay? Here's one that says this one's done from a suprasternal notch window. And then over here from a right sternal border window. And we have to see that you've done two from a non-apical window here. So you might imagine if you didn't have these labels on them that we couldn't tell, you know, is this right sternal or is it suprasternal notch? We can't really tell if you've done them from multiple windows. So it's always good to put the labels on there just so we know. It helps us know that you know what you're doing and that you've attempted these from several different windows here. I know this can be one of the most challenging things a sonographer does. Some of the things you can do to help improve your PDOF is, you know, make sure you've, once again, expanded your Doppler, your scale, and your sweep speed here because we're going to be tracing these, okay? Sometimes with aortic stenosis, they can be these little narrow waveforms here and be really difficult to trace and everything. So make sure that you spread them out vertically and horizontally so they're easier to trace out and to measure. Other things that maybe help you is notice how we've applied the color to the Doppler tracing. That can sometimes on some of these lighter gradients that you obtain help you see to trace those adequately up in this area here. So you know, any help you can get, we need on these sometimes. So they can be very difficult to get on some of these patients. Unfortunately, we see a lot of patients with aortic stenosis that are elderly patients. They have very small rib spaces. They don't like the PDOF probe. It's got little sharp edges on it, and we're really jamming it through their intercostal spaces trying to obtain these different gradients. So it can be something very difficult for us to do. One of the things we do in our lab is if you have an aortic stenosis patient, you can't get all three of the windows here, is we have additional sonographer come in and make an attempt. And, you know, sometimes they can't get it either, but at least we've tried. We've done everything we can for the patient to try and get them from all three windows. And you'll be amazed. Sometimes just a little bit different angle, a little bit different, having them roll a little further onto their right side, things like that, can really make a difference. And with that second sonographer attempt, you know, most often we'll go ahead and get a decent gradient on them. So, but I can't stress how important this is right here, especially for your exams that you're turning in for your ICAEL reviews. Just make sure that you got great waveforms, you know, that you're turning in your best work on these patients, and that we're seeing gradients obtained from all three of the views with the PDOF probe. So very important thing for you. Sometimes it can make or break whether you get accredited or not. So another thing I want to talk about is tracing the Doppler signal. And I think everybody would obviously say this is a bad trace. This is a sonographer who really didn't take their time to bring this around here and really hug that spectral waveform there. They just kind of sloppily traced this out here and didn't really go right up to the edges of it. And remember, this is a patient that we're looking at their aortic gradient here. So we're looking at a mean gradient, and we know that a mean gradient takes into account all the tracings all the way around there. So it's like an average of all these different velocities. So we want to make sure that we really make a good trace and really go right around that signal. Again, another good reason why to spread the signal, you know, both ways. It makes it a little easier to trace. I think you've noticed the tracing on the right side is actually a much better trace, a good trace, where the sonographer's gone right around the edge here and really done a good trace, took their time. So, and I think all this is, you know, just taking their time to ensure that the traces are good. Okay, so to recap what we've talked about with Spectral Doppler here, make sure that you expand the scale. Also increase the sweep speed. These two right here will help a lot in making your measurement. Also, utilize your color Doppler to help place the Spectral Doppler cursor. You know, if you're looking at a patient with aortic stenosis, you know, use the color Doppler to help you line up your signal there. Also, check your gain settings throughout your your echocardiogram just to ensure that your signals are set properly. Okay, next we're going to talk about tissue Doppler. More and more labs today are doing tissue Doppler. We know that when we obtain our tissue Doppler, the spectral study, that we need to be parallel. It's still Doppler here. Even though we're looking at tissue, we're still using Doppler, and we're using pulse Doppler here, okay? So we know with diastology, or diastolic, our septum here is shifted downward. And during systole, it's shifted upward, okay? And we know it's kind of shifted in this plane right here. So if we take our Doppler sample volume here and go across here, we're at quite an angle there, versus if we just would line the Doppler up here to where we're looking right down on the tissue that we're looking at here, you know, whether it be the septal wall, or if we move over here to the lateral wall, we want to just kind of shift the transducer up here to where we're lining that tissue annulus up there with our Doppler signal. And I'm going to show you some examples of this here. Here's one that we're just kind of slightly angled, you know, but remember, you know, what are our physicians doing with this information? Our physicians look at the velocity here. If we're at an angle here, what that does is it decreases this velocity here, okay? So this velocity is not as high as it should be on this particular patient, and it could alter the results. Here we've kind of slid more over the lateral wall here, the lateral annulus, to where we're looking pretty much down at the movement here that's going to go back and forth like that. So we're a lot more parallel to the wall motion or the annulus motion there. So, and we've also spread the signal out here where we can see the diastolic component here going below the baseline, okay? And we actually got a little higher velocity on that E wave there by doing that. So, you know, and this becomes even more important when you go across here and you look at your septal annulus here, okay? You would be at even more of an angle. So, you know, what we asked our sonographers to do is just to slide over, you know, line it up, line that annulus up to where you're parallel to that flow. Okay, next we're going to talk about sample volume placement here. And this is another area where it's very important is in our left ventricular outflow tract. Again, this is a measurement that we include in the continuity equation when a patient has aortic stenosis. It's one that can really affect your outcome in your valve area there if it's, number one, not placed parallel to the flow through the left ventricular outflow tract, or if it's placed too far down near the valve. So, you know, we always know that the outflow tract has a little bit of an angle to it. So we want to try and line that up to where it flows down there, and we tell our sonographers, go down, bump up against the valves. You'll see the valve spikes. You'll see the flow acceleration there, and then just kind of bump back out of it, go back out into the left ventricular outflow tract. You know, we like to see them about at the same level where they measure the left ventricular outflow tract, you know, just outside of the flow acceleration there. So, you know, again, we need to be parallel to flow, and we need to be outside of the flow acceleration. Again, a very important measurement here for our continuity equation. Another example of our sample volume placement is when we're doing our diastology study and we're looking at our mitral valve inflow. Okay, you can see here's an apical 4-chamber view. Here's our sample volume right here. What we tell our sonographers to do is to place the sample volume with right at the mitral valve leaflet tips when the mitral valve is opened. Okay, you know, sometimes when a patient's heart becomes dilated, we'll see the annulus shift more to toward the lateral wall. So we like for them to line that up as well. And we also like them to look at the waveform. You can see just by moving it here, kind of how the waveform changes, okay? And this will, by really watching this and setting it at the optimal location, will allow you to get these real spiky type waveforms here. and to get a higher velocity and to measure these a lot more accurately than if we just put this up there and don't really pay attention to where we're placing our sample volume here. So good rule of thumb, place it at the mitral valve leaflet tips when the mitral valve is opened. Okay, other ideas for improving your Doppler exam is to adjust the 2D image to become parallel to the flow. You know, if you're looking at flow over a valve, just kind of center the valve in the image there. So you'll pretty much be looking right down the barrel of the valve and obtaining your Doppler parallel to the flow. Also, you know, this may mean that you foreshorten the image, and foreshortening the image is not always a bad thing. Again, utilize your color Doppler for the sample volume placement. This is something that will allow you to help to find maybe the highest gradient on the patient or the best place to obtain your spectral Doppler. Also, you can utilize saline contrast or left ventricular opacification contrast to improve your Doppler signals. So I'm going to show you an image here where we've obtained a tricuspid regurgitation signal, and we're scanning from an apical four-chamber view here, and you can see how the sonographer has angled over here to the tricuspid valve. So what do you think the chances are that they're parallel to the regurgitant flow here? Probably not very good, okay? Look at our waveform here. The waveform's very faint. We don't have a good signal or a good envelope there for measuring. So, you know, these can become very important when we're trying to rule out pulmonary hypertension here. So another view here on the right side, you can see how the sonographer has slid the transducer a little medial, okay? We're now, the apex here is more of the RV apex rather than the LV apex, and we're looking right down the barrel of the tricuspid valve at the regurgitation. And also, I want you to notice the difference in the Doppler signal. Much better spectral Doppler signal, easier to measure, and probably a lot more accurate here, too. Notice the sonographer has also added the color here to help see the spectral Doppler much better as well. So just a technique that I think will help you throughout your study here. Okay, here's a saline contrast study. We do a fair number of saline contrast studies. We do a lot of patients that have had TIAs or strokes and stuff, so we're looking for a communication at the atrial level on these patients or a patent foramen ovale on these. So we, again, do a fair number of them. How we do these is we draw up bacteriostatic saline in a 10 cc syringe, leaving about a half a cc of air there. We connect them, two syringes up via a three-way stopcock, and we swish the saline back and forth until it becomes frothy. And what I mean by that, it becomes milky looking. So the bubbles are kind of diffusely throughout the saline, and then we bolus this in through an arm vein, okay, or through, you know, an existing IV they may have. And you can see here that the bubbles come into the right atrium, into the right ventricle. We have them do a valve salvo, which increases the pressure on the right side of the heart. And if there is a patent foramen ovale, it will push the bubbles over into the left side of the heart. And there you can see the bubbles come over. So this was a positive saline contrast study. Okay, the reason I included this is I wanted you to see what it could do for your Doppler exam. Patient that we're trying to desperately get a TR gradient on. We do a saline contrast study on this patient, and because this was our initial attempt at tricuspid regurgitation here on the left side, not much of a gradient here that we could get, or at least not a measurable one. So what we did is we lined it up a little bit better here. So we're looking down right through the tricuspid valve. We've added the saline, and what we do is we wait till it dilutes out a little bit. If you don't wait till it dilutes out, you get a lot of these little spiky things here. A lot of times they'll be way on down here, and you can't even see where to measure. And you can kind of see how it goes from here to here to here, and you get rid of those spikes, and you can actually see where to measure the tricuspid gradient at there. So just a technique that may help you on your more difficult patients when it's really imperative that you get a TR gradient. Okay, now I want to talk about foreshortening. And again, this is something that we as reviewers, as a question we have to answer on the review form. Did you foreshorten your apical images? You know, and this is something we look at with transthoracics and with stress echo. Here is a quad screen of an exercise echo, and we have the resting image in the top left, the in-post image in the top right, and then our recovering image in the bottom left. And you can see in our resting image where the apex of the left ventricle looks a little too thick, okay? As compared to the in-post image, the in-post image looks a lot more elongated. So this kind of tells me that this person foreshortened the apical four-chamber view in the resting image here, okay? So we like to see these very elongated ventricles. Apex should not be thickened there, and so it kind of alerts you to that there may have been some foreshortening there. We want to make sure that we see the entire apex on these views, just so we can evaluate that coronary territory as well, and we don't miss anything. You know, by foreshortening the apex, you can miss an apical thrombus, an apical wall motion abnormality, a lot of things there that could be missed. So we need to make sure that, number one, we start scanning at the lowest possible apical window where we can see the entire heart there, and then you know, as we find that we can image it adequately, at that point, then we can move up to a higher rib space. But we like to image down as low as possible to ensure that we're not foreshortening the ventricle there. Okay, remember that foreshortening can be your friend, okay? Sometimes when we're trying to get a TR gradient, we can see that on this particular image here, that by foreshortening the right ventricle here, because we're not really interested in the image, we're interested in the Doppler, that we can actually move up. We're closer to the valve, closer to the gradient here, and actually get a better gradient there. So our next image is one of vena cava. Get that there. Okay, and this is something that I like to show you here, because this is something that we routinely do in our echocardiograms now. We have to go through a lot of gas through the midline epigastric area there. This can sometimes be difficult to image there, but we like to watch the vena cava collapse and expand with respiration and expiration there. Also notice you can see the hepatic vein dumping directly into the vena cava there as well. So. Okay, if we can move on to the next slide. Okay, the next slide is that of hepatic vein. This is something that we've incorporated into our protocol several years ago, where we actually look at the hepatic vein. We try and look at it with color first, and another good area where you may want to decrease your color scale just so you can adequately image the hepatic vein and localize it. We look at these sometimes with patients who have more of the severe tricuspid regurgitation, because you can see reflux all the way back into the hepatic veins, and that would indicate that it's severe tricuspid regurgitation. We also look at these with pulse Doppler there as well, and obtain a spectral Doppler signal when doing these. So just some things that may help you. If there's gas down in the epigastric area, you may want to try going around to the patient's ribs and scanning through the ribs, through the liver to you know, avoid the gas in that area, and you know, it may actually help you to see the vena cava and the hepatic vein as well. So at this point, I think I'm going to stop there, and if we can get Brandon back on, we're going to move ahead and go ahead and move to the question and answer part of this presentation. Again, I would just like to recap, and I like to call these the golden rules of echo. You know, image your structures as perpendicular as possible, obtain the Doppler signals as parallel as possible. And these are like the two golden rules that I think you need to remember throughout your presentation there. So.
Thank you, Pam. Before we begin the question and answer session, we would like to remind you that this webinar is worth 1 SDMS CME. In order to be eligible to receive the CME, each individual must have registered for the webinar and accessed or logged into the web presentation. Within a few hours after the webinar, the attendees who registered and successfully accessed the presentation will receive a survey to the email address provided at registration. The final step for CME eligibility requires each attendee to individually complete the survey by January 18th. You must complete all 3 steps to receive the CME. No exceptions will be made. Approximately 2 weeks following today's presentation, the certificates will be sent via email to each attendee who completed all the steps of eligibility. And we will now begin the question and answer portion of the webinar. If you have a question, please.
I'm sorry,
go ahead.
We'll go ahead to 2:15 for the question and answers.
Okay, great.
Okay.
If you do have a question, please press star 1 on your touch-tone phone. To be removed from the queue, please press the pound sign or hash key. There may be a delay before the first question is announced. If you're using a speakerphone, please pick up your handset first before dialing. Once again, if you have a question, please press star 1. And on the line, we have Rita France. Please go ahead.
Yes, I've got a question regarding contrast usage, Pam. In our laboratory, we're using somewhere around 10% of our total adult and stress volume, and I've been questioned/harassed by administration because they think that's overusage. Is that approximately what you're experiencing in your lab?
Yeah, we're right, definitely in that ballpark. We've been using contrast so long that I think we probably use it a little more than 10% of the time. We're a fairly big stress echo lab, and you know, after a sonographer gets burned a couple times on the in-post images, I think you realize that you need to have a lower tolerance for using it. And I would just argue back that it's better to get the information on that particular study rather than having them to, get charged for several studies to get the information. So I think you're using an appropriate amount.
Oh, thank you. It's nice to hear that. We've been using it since 2002. I'm a big proponent of that, and you're exactly right. I mean, in stress echo, it's almost a necessity. I mean, you just can't do without it.
Right.
So thank you very much.
You're welcome. Thank you.
We have Stephanie Freeman online. Please go ahead.
Yes, she mentioned with the mitral inflow, placing the Doppler at the leaflet tips with the valve open. Can she clarify that a little more?
Well, I'm afraid you couldn't see my example there very well, but if you can just imagine from an apical 4-chamber view, when the mitral valve is opened at the leaflet tips there, you would want to place your sample volume there, and that would be a good location or a good target for you to kind of hit when you're obtaining your mitral valve inflow.
So it's not, is it at end diastole? And not complete systole?
Well, you want to, just when the mitral valve is open. I mean, I wouldn't really say a certain part of that cycle, but just when you see the valve open, just try and locate it within the leaflet tips there while it's open.
Okay, thank you.
Mm-hmm.
We do have a few additional questions. Please stand by. And we have David Bozart online. Please go ahead.
Hi, panel. This is Dave Bozart in Las Vegas. I work for a mobile company, and we do not use contrast at all. Is that going to be a problem?
I think really contrast is something that this day and time that you have to have. You know, if you're especially if you're doing stress echo. We not only use it on our difficult patients, and our what we tell our sonographers, if the echocardiogram is ordered for left ventricular function, then if we can't adequately see it, and we use the ASC guidelines, about seeing so many segments and all that, if they can't adequately see it, then they need to move ahead and utilize contrast.
Right. I guess the problem I have is that we work in nursing homes and rehab hospitals where trying to get somebody to administer that.
Mm-hmm. I think that in most states, and you would want to check it for your state, but sonographers can administer contrast.
Okay. And the other question is, I didn't see M-mode on the presentation. Are we not doing M-mode anymore?
Our lab doesn't do M-mode anymore on a routine basis. We do it for certain pathology states, but we do not do M-mode measurements or, anything like that on a routine basis.
So you basically do 2D from the parasternal long axis for the LV, and you also do Simpsons on all patients?
Yes, we do a Simpsons biplane on all patients.
Okay. Okay, that's something I hadn't been used to doing. I was only usually doing those on patients with segmental wall motion abnormalities.
Yeah, we do them on everyone.
Okay, and that's part of the ICAEL guideline, I guess. I haven't looked at that recently, but okay. That is.
Thank you, David. We have another participant that would like to ask a question. Brandon is going to put through Kara Breath.
Hello.
Yes, Kara, please go ahead.
Okay. I work at an inpatient in a hospital, and I was just wondering what your protocol is for using Vicinity. Do you guys have just a standing order, or do you have to find a physician to get the order? We're just kind of trying to revamp our policy, and I'm just wondering what you do, where you practice.
Okay. Well, before the black box, the sonographers were making the decision when to use contrast. Mm-hmm. We kind of stepped back at that point and required a physician approval for it. We're probably very fortunate in that we always have an attending with us in our reading room because we're a fairly large echo lab. Mm-hmm. So we can walk in there. They can look at the images that have come through digitally and help us make that decision. I have a feeling probably in the next 3 or 4 months we'll go back to the sonographer making the decision once again to utilize contrast. So,
okay, thank you.
You're welcome.
And we have Asmi Syed online. Please go ahead.
Yes, actually, regarding sample volume size, I use for mitral valve inflow a different size. I use usually a smaller size. When I go to pulmonic vein, I use larger size. Is that the protocol for your site?
We really don't change it that much. We pretty much go with what is preset into the equipment and don't really change it throughout the study unless we absolutely have to get a waveform there. But I think increasing it can always help you obtain a waveform.
Exactly, yeah.
So I think what you're doing is okay.
That's what I do usually for pulmonic vein. Sometimes when I make it 4 or 5 millimeters, mm-hmm. It gives me way much better waveform systole, diastole, than if it's smaller.
Right.
Thanks.
Mm-hmm.
And we have Douglas Foreman online. Please go ahead.
Hello.
Hello.
Hi. I had a question as far as on your parasternal long axis view when you are making measurements with your 2D. A lot of times your basal portion will be moving adequately, but then as you get more out towards your apex, a lot of times it'll balloon out and the measurement is much greater there. Would you go ahead and measure it there towards the mid portion to the apex, or just keep it right there at the basal portion?
Well, that was the example I showed was one that had more of a basal focal area of hypertrophy. Mm-hmm. And, it was just giving you a tip to avoid that area and to kind of move down on the septum there to where it kind of normalized out, and was a normal segment of the septum.
correct. A lot of times, though, if you have like a cardiomyopathy there, where the basal portion is moving, and then as you get really out towards more the midsection, it really gets a much greater dimension. Would you go ahead and go even out towards the midsection to measure that, where it would have a much greater dimension?
Yeah, I probably would. I would, just stay right about the level of the chordae, though. I wouldn't go much past that.
Okay. Well, sure. Thank you.
Thank you.
We have Brad Mell online. Please go ahead.
Hi, Pamela.
Hello.
I have a question about accreditation in aortic stenosis. If we are going to submit a study for AS, which is required, but the patient is in AFib, would accreditation want us to measure 5 beats in a row? Would we be dinged if we didn't?
I think you're probably opening a can of worms here.
Okay. All right.
Bev, you can help me here. I would look for a better study.
Look for a better study.
I think you're just opening a can of worms.
Okay.
I agreed with Sam.
Okay. What about if you had just a routine echo you're going to submit? Do you recommend multiple, like LVOT gradients to be measured, or is one sufficient?
In our lab, we do two.
Okay.
It's in our protocol. I don't think ICAEL requires you to do two.
Okay.
No.
Okay. That's what I had.
Okay.
We have Greg Breedlove online. Please go ahead.
I had a question about submitting aortic stenosis for ICAEL accreditation. When we do our PEDOF, I'm getting a question. Is it okay that it is showed that we attempted all views, or on every view, suprasternal notch, right sternal border, do we also need to show an envelope that we traced?
Can you repeat that again, please?
When submitting an aortic stenosis test for ICAEL accreditation, I'm getting a question when we do our PEDOF. Is it enough that we attempted the views and showed them and labeled them, or do we need to show an envelope that was obtained well enough to trace for submission?
Remember what we are asking for your best studies. And so if you've got a study that, there's an envelope present in all 3 views, then I would definitely send that study over one where you were just making attempts.
Okay.
So, it's not required that you have good envelopes in every view, but,
that's ideal.
We are asking for your best work. Bev, if you want to add anything.
Yeah, the standards do require one clear envelope from a non-apical window. So whether it be, right sternal border or suprasternal notch, we do ask that you get one clear envelope from a non-apical window. So, if your apical window velocity looks great, but your right sternal border and suprasternal notch aren't very clear, then that's not a case that I would submit.
Okay, thank you.
Well, we are almost out of time. Beverly has some exciting news she would like to share with us. Bev?
I do. Thank you, Brandon, and thank you, Pam, for an excellent presentation. Many of you may know that the ICAEL is one of 6 divisions of the Intersocietal Accreditation Commission, or IAC, and in the next few weeks you'll notice our new look as one IAC. We'll also be offering many more products and services to help to streamline the process and to help you with the process. So please be sure to watch your mail and inboxes for more exciting news. And with that, Brandon, I think we'll end.
Great, thank you. If your question was not answered during the presentation, or you wish to ask your question privately, please email or contact the IAC